Today I am going to discuss the topic of arterial blood gas analysis, aiming to simplify it. Arterial blood gas analysis can be difficult to understand, however, it provides a near immediate reflection of the patient's physiology. This is part 1 where we will discuss only the basics of ABG. In part 2, 3 and 4 we will discuss how to read ABG in a step-by-step manner, including validity, oxygenation status, ventilation status, approaches to metabolic acidosis, anion gap, delta anion gap, floral responsive and non-responsive metabolic alkalosis, and approaches to acute and chronic respiratory acidosis and alkalosis. And in last part we will solve 10 ABGs problems from standard textbooks, including triple acid base disorders. So let's jump straight in. So you can observe 2 bottles. The first bottle contains sulfuric acid, phosphoric acid, lactic acids, and meanwhile the second bottle contains only carbonic acid or the carbon dioxide. So can you identify any difference between these 2 bottles? It's quite simple. The second bottle has a cap. The reason is that it contains carbonic acid, which is volatile. So therefore it needs to be closed, otherwise it will disappear over time. So the second bottle contains volatile acids, while the first contains non-volatile acids. In our bodies we also have these 2 types of acid, volatile and non-volatile. They play a crucial role in normal cellular ionic reactions. These acids are continuously produced in our bodies and excreted from our bodies, creating a constant acid load necessary for the normal functioning of our body. Volatile acids are produced and expelled through the lungs, while the non-volatile acids are eliminated through the kidneys. But there will be always an acid load in our body and should be there for normal cellular ionic reactions. Suppose I were to pour all this acid into the glass, you can see volatile and non-volatile acids. For understanding purpose, consider this glass as a body, and I am pouring all our body acids into the glass. So we have 2 types of acids in our body, volatile and non-volatile. These acids are essentially hydrogen ions or proton donors, and they need to be in a normal range for typical cellular reactions. Do you know how much acids you have in your body or in my body? I mean, how many hydrogen ions? A person without any underlying issues typically will have 40 nanomoles per liter of hydrogen ions or acids in their body. So one simple question, why do we take ABG? One reason is to know the level of acids, right? So now I will show my ABG and tell me what is my acid level or how much hydrogen ions I have in my body. It should be normal and it should be 40 nanomoles per liter, right? So this is my ABG. How much acid I have or how much hydrogen ions I have by looking this ABG? pH 7.4, PO2 98, PCO2 40 and BiCarb 24. So I told without any underlying issues I should have 40 nanomoles per liter of hydrogen ions in my body. Where is this acid level or where is the 40 represented here? Here 7.4. 7.4 indicates a normal acid level or normal hydrogen ions, which is 40 nanomoles per liter. So a pH of 7.4 means a person has a normal acid level consisting of 40 nanomoles per liter of hydrogen ions. So now look at this chart. This chart shows the relationship between pH and the amount of hydrogen ions in our body. See, 7.4 means 40 nanomoles per liter of hydrogen ions, that is normal level. Suppose if the acids increases in our body, so what will happen to the hydrogen ions? This 40 will become 50, but pH falls or drops. And if the acid increases further more, now 50 will become 60 and pH drops again. So you can see here pH is falling when acids or hydrogen ions increases. Now just opposite, if the acid decreases in our body, then this 40 will become 30 and 25, and you can see pH is increasing. So what is pH and what does it mean? pH full form is the potential of hydrogen ions. pH indirectly shows the amount of hydrogen ions or acid level in an opposite way. So pH is the negative logarithm of hydrogen ion concentration. These are hydrogen ions. And so what is normal pH? 7.4. So a pH of 7.4 means a person has a normal acid level consisting of 40 nanomoles per liter of hydrogen ion. Now see this ABG. pH 6.9, PCO2 12, PO2 108 and bicarb 2. This ABG shows that this patient has 125 nanomoles per liter of hydrogen ions in his body. So now you know what is pH. pH is the negative logarithm of hydrogen ion concentration. Now we'll show you what is an acid. This bottle contains acids or hydrogen ions, for example sulfuric acids. So acid is a substance that can donate hydrogen ions when added to a solution, rises hydrogen ions and lowers pH. And what is a base? Base, for example soda bicarb, is a substance that can accept hydrogen ions or when added to a solution lowers hydrogen ions and rises pH. So pH is the negative logarithm of hydrogen ion concentration. And now we'll learn full forms. pH, what is pH? Potential of hydrogen ions. PO2, partial pressure of oxygen. PCO2, partial pressure of the carbon dioxide, and HCO3 is bicarbonate. So now we will see the normal values in ABG. Even though these values are considered to be normal, for calculation purpose always use normal pH as 7.4, normal PCO2 as 40, normal bicarb as 24. Here we can see 4 in all values, 4, 4, 4. So what are the normal values? pH 7.4, PCO2 40 and bicarb 24. pH 7.3, what is this? Acidemia. Why? Because this is less than 7.4. If the pH is less than 7.4 means patient has acidemia and the condition is called acidosis. This all represents acidemia because these all are less than 7.4. pH less than 7.4 means patient has acidemia. pH 7.5, this is alkalemia because this is above 7.4 and the condition is called alkalosis. This all represents alkalemia because they all are above 7.4. pH above 7.4 means patient has alkalemia. Acidosis is a condition that develops when pH is less than 7.4 and alkalosis is a condition that develops when pH is above 7.4. We have 4 types of acid-base abnormalities: metabolic acidosis, metabolic alkalosis, respiratory acidosis and respiratory alkalosis. So this is non-volatile acids which contain sulfuric acid, phosphoric acid, etc. And when non-volatile acid like sulfuric acid, phosphoric acid are more in our body than normal range, we call it as metabolic acidosis. So metabolic acidosis means non-volatile acids are more. And if the non-volatile acids are less, bicarbonate will start to increase and patient will develop metabolic alkalosis. So metabolic alkalosis means less non-volatile acids or less hydrogen ions or less acids. So when volatile acid increases, that is carbonic acid or carbon dioxide, we call it as respiratory acidosis. When it is decreased, patient will develop respiratory alkalosis, means low volatile acids. So once more, there are 4 acid-base abnormalities: metabolic acidosis, metabolic alkalosis, respiratory acidosis and respiratory alkalosis. Example for metabolic acidosis includes renal failure, decay, diarrhea. An example for metabolic alkalosis include vomiting, Cushing syndrome, hypokalemia. Example for respiratory acidosis include CNS depression, COPD or any conditions or illness which can lead to increase in carbon dioxide. An example for respiratory alkalosis include anxiety, fever, liver failure, any illness which can cause patient to hyperventilate and reduce carbon dioxide in our body. Now look at this patient ABG. This patient has presented with acute renal failure. pH is 7.2 and bicarb is 14. As I told, we have 2 types of acids, volatile and non-volatile. In acute renal failure, non-volatile acids start to build up because the kidneys are not functioning and fail to excrete non-volatile acids through urine. When non-volatile acids increase, it is called metabolic acidosis. When a person develops metabolic acidosis, hydrogen ions are elevated. High levels of hydrogen ions in the body can lead to many complications, so the body must reduce them. There are several mechanisms to reduce hydrogen ion levels. The first being the buffer system. Our body has a buffer system which can accept or release hydrogen ions. Bicarbonate is one such buffer, and we have 24 milliequivalent per liter of bicarbonate in our body. Bicarbonate binds with the hydrogen ion to form carbonic acid, which then splits into carbon dioxide and water. This process acts quickly to neutralize hydrogen ions, thereby improving pH. So, what will happen to the bicarbonate? It starts dropping or decreasing. So, whenever you see a low bicarb in an ABG, that means patient has an increased non-volatile acids or metabolic acidosis. So, why bicarb is low in metabolic acidosis? Because bicarbonate has utilized for buffering or for neutralizing hydrogen ions. And now, after some times, body will use a second mechanism. We have volatile acids in our body. So, patient will start hyperventilating to remove some volatile acids or carbon dioxide, so that the whole acid load will be reduced, and this is called the respiratory compensation. So, in metabolic acidosis, pH will be low. Why? Because hydrogen ions are more. Bicarbonate will be low. Why? Because it has been utilized for buffering. PCO2 will be low due to compensation. Patient will start hyperventilating to remove carbon dioxide. So, metabolic acidosis occurs when non-volatile acids are more in our body. Remember these arrows in metabolic acidosis. In metabolic acidosis, pH will be low, bicarbonate will be low, and PCO2 will be low due to compensation. So, now see this ABG, pH is 7.2. So, patient has acidosis. We don't know which acidosis. It can be either metabolic or respiratory. To know this, look at the bicarbonate. Here it is 14. That is low. So, definitely patient has metabolic acidosis. In metabolic acidosis, bicarbonate will be low. Why? Because bicarbonate has utilized for buffering. It happens only when non-volatile acids increases. So, when non-volatile acids increases, we call it as metabolic acidosis. So, now remember this arrow in metabolic acidosis, all are on the lower side. pH low, bicarbonate low, and PCO2 should be low due to compensation. pH low, bicarbonate low, and PCO2 should be low due to compensation. Now, don't look at the PCO2 in this ABG. We have to calculate the expected fall in PCO2 in this particular ABG by using a formula. Patient will hyperventilate and PCO2 should be on the lower side. The expected fall in PCO2 will be 1.5 into bicarbonate plus 8. So, after using this formula, the expected fall in PCO2 will be 29. So, if you get this value, we call this ABG as a partially compensated metabolic acidosis. That means the patient has only metabolic acidosis, that is single acid base disorder, for example renal failure. Why partial compensation? Because pH is low. To tell full compensation, pH should be in a normal range, which rarely occurs. Here the patient is having only metabolic acidosis. Now listen very carefully, the most important part. This is the expected fall in PCO2, 29. So we got it from the formula. Instead of this, if you see in the ABG a higher PCO2 than expected, or what we calculated, for example 40, if you see this in the ABG, then you will tell that this patient has metabolic acidosis and respiratory acidosis also, because the carbon dioxide is here is more than expected. So this is a dual acid base disorder. For example, patient presented with renal failure and COPD. Second, this is the expected PCO2. Instead, if you see here a lower PCO2 like this 20 in the ABG, then we will tell that this patient has metabolic acidosis and respiratory alkalosis also. That means again dual acid base disorder. For example, patient presented with renal failure and anxiety. Here the patient is hyperventilating, so he is washing out more carbon dioxide. So once more, in metabolic acidosis, pH will be low, bicarbonate will be low due to buffering, and PCO2 should be low due to compensation. Remember these arrows again. In metabolic acidosis, pH will be low, bicarbonate will be low, and PCO2 will be low due to compensation. PCO2 we have to calculate by using this formula to know whether the patient has only metabolic acidosis or not. Because in ABG there can be multiple hidden disorders. single acid base disorder, dual acid base disorder, and even triple acid base disorder. So now metabolic alkalosis. Metabolic alkalosis occurs when non-volatile acids are less. Look at this ABG, pH 7.5. Here the pH is high, so the patient has alkalosis. It can be either metabolic alkalosis or respiratory alkalosis. To confirm this, first look at the bicarbonate. Here it is 34. It's high, so patient has definitely metabolic alkalosis. In metabolic alkalosis, PCO2 will also be high due to compensation. Here the patient will hyperventilate and try to bring the carbon dioxide to a higher level to maintain the pH. Remember these arrows in metabolic alkalosis. pH will be high, bicarbonate will be high, and PCO2 should be high due to compensation. Here also don't look at the PCO2 in the ABG. Here we have to calculate the expected rise in PCO2 by using this formula. The expected rise in PCO2 in metabolic alkalosis will be 0.75 into change in bicarb plus 40. Here it will be 47. So change in bicarb means 34 minus normal bicarb. If you get this value, that is 47, you can tell that this patient has a partially compensated metabolic alkalosis. Here the patient has only metabolic alkalosis and no other abnormalities present. Now listen carefully. Instead, after using this formula, if you see a higher value than expected like this, for example 55, then the patient has metabolic alkalosis and respiratory acidosis also, because here the PCO2 is much more elevated than expected. And if you see a value lesser than this, for example 35, then the patient has metabolic alkalosis with respiratory alkalosis also, because the patient is hyperventilating. In metabolic alkalosis, all are on the higher side. pH high, bicarb high, and PCO2 will be high due to compensation. In metabolic acidosis, all are on the lower side. pH low, bicarbonate low, and PCO2 will be low due to compensation. In metabolic acidosis, we have to find the expected fall in PCO2, and in metabolic alkalosis, we have to find the expected rise in PCO2. Now, respiratory acidosis. Respiratory acidosis means volatile acids are more. Respiratory acidosis occurs when some illness that causes retention of carbon dioxide in the body and rises PCO2, for example COPD patients. Remember these arrows in respiratory acidosis. pH low, and rest both PCO2 and bicarbonate will be on the higher side. Here we have to find the expected rise in bicarbonate. pH low, so patient has acidosis. And PCO2 here it's high, so patient has respiratory acidosis. In respiratory acidosis, bicarbonate will also be high due to compensation. In respiratory acidosis, patient will try to retain bicarbonate to bring pH to the normal range. Now see this ABG. pH is low, 7.1. So the patient has acidosis. It can be metabolic or respiratory. To know this, first look at the bicarbonate. Here it is 28. Here that is elevated. So there is no metabolic acidosis. In metabolic acidosis, bicarbonate should be low. So now look at the PCO2. Here it is 80. It is high. Since PCO2 is high, patient has definitely respiratory acidosis. In respiratory acidosis, bicarbonate should be high due to compensation. Patient will try to retain bicarbonate. Here we have to find the expected rise in bicarbonate by using a formula. The expected rise in bicarb in acute respiratory acidosis will be 0.1 into rise in PaCO2, and here it should be 28. To know acute and chronic, we will be discussing in part 2. So the expected rise in bicarbonate in acute respiratory acidosis will be 28. If we get this value, then the patient has only respiratory acidosis. But instead, if you get a bicarbonate value higher than expected like this 40, then the patient has associated metabolic alkalosis also. So this patient has respiratory acidosis and metabolic alkalosis also. And if you get a bicarbonate value that is lower than expected like this 25, then the patient has associated metabolic acidosis also. So the patient has respiratory acidosis and metabolic acidosis. So once more, in metabolic acidosis, all are on the lower side. Arrows will be like this: pH low, bicarbonate low, and PCO2 will be low due to compensation. And in metabolic alkalosis, all are on the higher side, pH high, bicarbonate high, and PCO2 will be high due to compensation. And respiratory acidosis, pH will be low, PCO2 will be high, and bicarbonate also will be high due to compensation. Now respiratory alkalosis occurs when volatile acids are less. What are the causes of respiratory alkalosis? Any illness that can cause washout or reduction in carbon dioxide. For example, anxiety. Patient will hyperventilate and will reduce carbon dioxide. Remember these arrows in respiratory alkalosis. pH high, so patient has alkalosis. PCO2 will be low and bicarbonate also will be low due to compensation. See this ABG. pH 7.5. That is high, so patient has alkalosis. It can be either metabolic or respiratory alkalosis. To know this, look at the bicarbonate. Here it is 19. That is not high, so patient does not have metabolic alkalosis. In metabolic alkalosis, pH and bicarbonate should be high. Now see the PCO2 here, it is 15, which is low. So definitely patient has respiratory alkalosis. In respiratory alkalosis, bicarbonate will be low due to compensation. Body will try to reduce bicarbonate to maintain pH. Now remember this arrow in respiratory alkalosis. pH high, PCO2 will be low, and bicarbonate will be low due to compensation. Here don't look at the bicarbonate in our ABG. This we have to calculate the expected fall in bicarbonate in acute respiratory alkalosis, and it will be 0.2 into fall in PCO2. Suppose this is an acute, and if the bicarbonate comes to this value, that is what we calculate like 19, then the patient has only respiratory alkalosis. Instead, if you get a higher value than expected like this 26, then the patient has associated metabolic alkalosis also. So the patient has respiratory alkalosis and metabolic alkalosis, dual acid base disorder. Instead, if you get a lower value than expected like this 16, then the patient has respiratory alkalosis and metabolic acidosis also. So once more, in metabolic acidosis, all are on the lower side, pH low, bicarbonate low, and PCO2 will be low due to compensation. Here you have to use the formula to calculate the expected fall in PCO2 to know whether the patient has properly compensated or not. In metabolic alkalosis, all are on the higher side, pH high, bicarbonate high, and PCO2 will be high due to compensation. Here you have to use a formula to calculate the rise in PaCO2. In respiratory acidosis, pH will be low and PCO2 and bicarb will be high, and here we have to find the expected rise in bicarbonate. And respiratory alkalosis, pH will be high and PCO2 and bicarbonate will be low. Here we have to calculate the expected fall in bicarbonate. In next part 2, 3 and 4, we are going to discuss how to read an ABG from standard textbooks in a step-by-step manner.